Bismillah ar-Rahman ar-Rahim. Our next speaker, Professor Dr. Ahmed Abdurrahman Hashim, Professor of Endodontics in Shams University and Future University, and the Secretary of the Egyptian Association of Endodontists. طبعا دكتور أحمد غني عن التعريف. دكتور أحمد من الناس اللي ليها أيادي بيضاء كثيرة على أسرة علاج الجذور على المستوى الشخصي وعلى المستوى العلمي وعلى المستوى الأكاديمي. أنا يعني I owe him a lot. اتعلمت منه كتير و it is my pleasure إن أنا أشاركه في السيشن ديت. فبليز ويلكم دكتور أحمد.
Thank you very much, Shihab. It has been a lifetime journey together, and I hope it will continue until one of us pass away. Okay, it's very difficult for me to lecture after Dr. Muhammad Hammu, because I know he done a lot of mental masturbation to you. So he prepared for me, because my lecture is going to be about apical periodontitis resolution. Is it really what we think about that? There was in the endodontics in the 90s, Kivest has introduced what we call it Baraxis theory, which says that general practitioner and endodontists, they react to apical health like if they have a line, and on this line, on one side, normal periapical area is perfect prognosis, while on the other side, when you have a large apical delucency, and I like to emphasize on this, in radiograph we say apical radiolucency. We cannot differentiate, and we cannot say apical lesion, because we don't really know what is inside. It's radiolucency. It's black area in the X-ray. And so in the right side, you have a large lesion, so this is a bad prognosis. Actually, does it work that way? Let's go through the lecture. And I like to emphasize in the beginning that it's all about microorganisms. Remember that. Our enemy is microorganisms, the bugs inside the root canal system. This has been identified by Miller in 1894 in Dental Cosmos, where he identified the three forms of microorganisms: cocci, bacilli, and spirochetes. Okay, later on, and I think most of you know this lecture by now, it's by Takahashi. It's not working. It will make me, I don't know what. Takahashi study in 1965, very simple study. I think by now most of you know it, where he had normal rats, germ-free rats, bulb exposure here, and he followed up. And normal rats, this is what happened in our patients. Bulbal inflammation, bulbal degeneration, necrosis, and apical periodontitis. What happened in germ-free rats? Nothing. Secondly, dentine formation. And of course, we have more advanced techniques now for isolation of microorganisms. We know that Sandqvist has proved that in the 70s, and we still believe in this. More than 90% of our microorganisms inside the root canal is anaerobic bacteria. One of the nice observations, which is discovered by Sandqvist and confirmed by Muller in 1983, that our necrotic bulb per se, if there is no microorganism, there will be no apical periodontitis. This is established fact. If you had a trauma, your patient had a trauma, bulbal necrosis, you don't have any vitality testing that give you negative response. Discolored tooth, the patient is asymptomatic, you do an X-ray, there is nothing in the X-ray. Mostly this is a necrotic bulb, but it was not yet invaded by microorganisms. Remember that. Yes. Do you have a, sorry? Go back, please. Yes, one more slide. Okay, this is what I told you about Muller. Next slide. And we know that biofilm, bacteria is not present in bronchitonic form. It's not free in suspension, like we thought in the old days. It's a biofilm formation present in sheltered areas. This biofilm is very difficult to eradicate. Do you think that your sodium hypochlorite, just using some kind of passive irrigation, is going to remove this biofilm? Actually, no. This is why a lot of research now is directed toward having shear forces inside the root canal system by using different methodologies to disrupt this biofilm so our irrigant will act effectively on it. And we should know that apical bone loss happens because of our immune system. About 60% of apical bone loss is due to interleukin-1 beta. 15% is due to prostaglandin E2. This is established in literature. So what happens, like the bacteria and bacterial byproducts, they stimulate the immune system. Immune system want to counteract these bacteria, prevent it from invading the bone, so they bring the immune system cells. Immune system cells want a place to stay. So you start to resorb the bone, they have a place. And after removal of the stimulus, bone reform again. Okay. One slide back, one slide back. Okay, go on. Okay, this is a very nice study by Domenico Ricucci and Seguera. They had in this study الحالتين دولت resistant infection. They tried root canal treatment and it does not work. So one of them removed it and the other one, they made an apical surgery. What they found that they had extra-radicular biofilm in the external root surface, which has been partially mineralized. So remember that sometimes in certain cases when you have a case which is not at all responding to treatment, you might have a situation like that. Extra-radicular biofilm which is there and you cannot get it from conventional root canal treatment. So we have an apical lesion. We have, sometimes we say that we have a cyst formation. What makes cyst? What is the theory? We have different theories there in the literature. Nutritional deficiency theory. We have abscess theory. And we have the third one, merging epithelial strand theory. I'm not going to go through this. You can find it in literature. But what I wanted to emphasize that we found that epithelial rests of Malazé, the same pro-inflammatory cytokines and inflammatory mediators which are secreted from the apical immune cells and responsible for apical bone loss is the same which is responsible for proliferation of epithelial rest of Malazé to form cyst formation. So we might think about that this proliferation of cell is not a pathological process, rather than it might be proliferative process as a defensive mechanism of our immune system to the irritant coming from the root canal system. So what is the nature of apical lesion? Of course, there is diverse in the studies. You are going to find a study like that. Study like that, if you look, granuloma, 52%, cyst is 42%. This is a little bit high percentage. But they found very interesting observation that granuloma is the more common, but in mandibular posterior teeth, apical cyst is more common. So remember that when you have a large lesion in the molar area, in the posterior molar area in the lower mandible, or the mandible might be going towards cyst. Of course, Nair in a series of studies showed us that we have different percentages of different apical delucencies. Abscess 12%, granuloma 73%, true cyst 9%, pocket cyst 6%. Dr. Muhammad in his lecture told you about the definition of both of these. But let me tell you that Nair done his studies on extracted teeth with apical delucency. But when you do surgery, it's very difficult to differentiate if it is a true cyst or a pocket cyst. This has been found in other studies. One other study found that preapical granuloma is 70%, while preapical cyst is 23%. So we have a range of something apical cyst that it's between 11-12% up to 23%. This is the average. And it differs from studies to study, and you cannot differentiate it, apical cyst from granuloma from radiograph or cone beam even. But you need a histology to differentiate. So how can I differentiate What is the diagnostic method I can really rely on? As I told you, some studies predicted what is the percentage. Look at this study. When the lesion size was 2 to 5.9 millimeter, they found the percentage of cyst is 5%. لما زاد ل6 من 6 ل 9 9.9 millimeter, it up to 14.3. When it is more than 9, 10 to 20 millimeter, they found that it's 35.5%. So whenever you have increase in the size of the lesion or the apical reducency, there is more frequency that you can find an apical cyst. But it's not conclusive. I like this study. This study based on cone beam. They tried to correlate what they found, the clinical and the cone beam, with the incidence of apical cyst. So if you have, they differentiated into less than 247 millimeter, cubic millimeter, and more than 247 cubic millimeter. What they found? If you have root displacement, you will have what? You will have 60% incidence of apical cyst, while 40 will be granuloma. If you don't have root displacement, 20% only apical cyst. This is in a lesion which is smaller than 247. But if you have a lesion which is more than 247 cubic millimeter, the incidence here, 80% to have an apical cyst. So this is some kind of give you. It's not conclusive. You cannot say that it's 100%, but it gives you a hint about what is going on there. This is one of my cases. This is upper lateral incisor. Go back please. كان افضل يبقى موجود فوق. اوكي انا كنت عاوزه يطلع فوق البوديوم ده بس للاسف. This is ممكن مره واحده بس عشان الفيديو يشتغل. لا جوه اهو مره واحده بس. اوكي. This is an upper lateral incisor. As you see, الريفيرنج dentist بعت لي الحاله دي علشان ما قدرش يوصل للكلام. It was calcified, but this is not the issue here. If you look at the axial view, there was a large apical reducency, which is by the sizing. If we measure the size, next. If we measure the size here is 700 cubic millimeter. Doing root canal treatment, regular root canal treatment, cleaning and shaving, obturation. Next. This is immediately, see the size of the lesion in the apical radiograph, and 1 year follow-up. Next. The lesion decreased. Not completely recovered, but usually these lesions take time. Whenever you have a larger lesion, it might take larger time or longer time to heal. Up to 2 years, maybe more than 2 years. Next, please. So what we are going to do? Do we have to go for large lesion to surgery? Of course not. We have a lot of things to do before we reach conservative treatment and other things to do. Next, please. Look at this study of large apical delucency in the central incisor, and what they do, they just do a root canal treatment. Proper root canal treatment, and the lesion decreases. This is a large lesion, they decrease in size. And actually, there is a strong coming evidence that even true cysts can heal by conventional root canal treatment. Next, please. This is another large lesion, as you see, and approaching an implant. Go back now. Large lesions, which is approaching an implant, and this is denying the talking about that lesions can affect the implant, and root canal treatment has been done. Calcium hydroxide has been placed there. 4 consecutive visits, 4 زيارات بتحط calcium hydroxide. Follow up, it healed. Next, please. And this is one of my cases. This case, I like it very much. It's very large apical delucency related to upper first molar. As you see, the delucency is extending to the maxillary sinus. If you can see, all this are delucency. You see this white margin here. And not only that, this was a retreatment case. And there was a missed second mesobuccal 2, and actually I could not reach, in this case, I could not reach the end of the canal. It was completely blocked and I could not reach. And the size of the lesion, next please, 4,281 cubic millimeter. I had done the root canal, which is not that perfect, and we followed up the patient. Next, please. And this is 2 years follow-up. Complete resolution of the lesion. Despite that, it was not the fancy treatment that I wanted to have in this case. Next. As you can see. Okay, what other methodologies I can use for such lesions? One of them, that I decrease the pressure, decompression. Decompression can be done by polyethylene catheters like this, and you shorten over time. Just like you are, this is, we call it decompression, just like marsupialization. But marsupialization is more aggressive treatment. This is a more conservative treatment. You do the root canal, and you put your polyethylene catheter, and you cut it every now and then, and this will decrease the pressure until you have healing. Next. This is a case which I have done with one of my colleagues, surgeon. Of course, we need collaboration sometimes. Next, please. This was a very large lesion, also related to the lower posterior area. Complete destruction of the buccal plate of bone. I have done the root canal treatment, and decompression have done by the oral surgeon. Next. This is 4,361 cubic millimeter. Next. And this is 4 months follow-up. Huge reduction in the size of the lesion. You see buccally, the lesion has decreased. It became now, after 4 months, 2,059 cubic millimeter. Next. What other? Aspiration and irrigation. You can do it. You can do the root canal treatment. You can aspirate with saline and irrigate with saline and aspirate. This will evacuate the irritant from the area, and the area might go into healing, like this case report published in Joey. Okay, next please. انت عملت لوحده. هو نقل لوحده، هو خلاص تعود عمل بيسنج. Okay, endovac. I think all of you familiar with endovac. It's the same concept that you decompress, you evacuate what is in the apical or beyond the apical area. So using endovac, here you are not going to use it in the regular technique, which is going to use macro cannula to the apical. You are going to put the macro cannula, push it inside the canal, so it will make a negative pressure, so it will suck what is below the tooth. Might work also. Next, please. Okay, this is one of my cases. The patient came with an abscess related to the upper lateral incisor. See how much pus coming out, and large reducence. Next, please. Large reducence was there. I evacuated the pus, and I put calcium hydroxide. I inject calcium hydroxide inside the canal. Okay, so you know everything in the science is a coin. It has two faces. What I am doing might be right in my opinion, but this does not mean that the other one is doing wrong. In science, always like that. You are going to have a lot of controversies, a lot of different opinions. But at the end, what we wanted to reach is the most important. This is the apical reducency. Next, please. And this is the size of the lesion, 2,662 cubic millimeter, and Next. This is, I think, about 1 year follow-up. Marked decrease. You notice that there was almost perforation lingual cortical plate of bone, and now it is reformed again. Next. Next. Okay, what other line of treatments we can do? Antibiotics? Yes, you can do a combination. You heard about triple antibiotic based, and you can use triple antibiotic based inside the canal, and this case report showed that it can work. Of course, meaning of all these techniques and case reports that are working, that there is something. If you arrive to the area that you can properly disinfect your root canal system, usually even large reducencies is going to heal. Next, please. This is a case series actually, and they use decompression through the root canal and long-term use of calcium hydroxide. And actually, all of their teeth, which was 10 teeth or 10 patients, they have healing, except one, which did not. And when they do surgery, what they found? What I told you in the beginning. There was a biofilm extraradicular which was partially mineralized. So remember that it's almost all about microorganisms. Next, please. This is one of my cases. Very large apical radiolucency. Actually, it was a retreatment case, and I kept bringing the patient. There was a weeping canal exudate. I put calcium hydroxide, and last visit, before I obturate, I was a little bit aggressive. So I inject a little bit more. So what I had, I'm going to show you the lesion in the beginning. What I had one click only. No, go back please. معلش يا جماعة. Okay, this is the radiolucency. As you can see, almost eroding the buccal and lingual cortical plate of bone. Okay, this is the size of the lesion. 4,880 cubic millimeter. I bought calcium hydroxide. This is what happened. I push calcium hydroxide outside of the canal. What's going to happen? Of course, it's not right to push calcium hydroxide like that, but this is what happened in this case, and I followed the case. The lesion was reduced in size. It's decreasing in size. Mostly, what I believe in this case, that what really happened that after decompression, that I kept decompression, I kept pus or fluid coming, oxidate coming from the canal, up till that the pressure inside decreased and the healing starts. The lesion became 964. This is 2 years follow-up. After 4 years, the patient came for follow-up, and there is still some radiolucency. I have the calcium hydroxide there. This is very resistant calcium hydroxide for solubility, but 4 years is still some radiolucency. What you are going to do? Are you going to interfere, or are you just going to follow up? Patient is asymptomatic. There is no signs and symptoms at all, and everything is okay with her. She is a female patient. I choose to follow up further, and I'm looking for 6 years follow up. Okay. Let's look at this study. This is very interesting study talking about possibility of healing after root canal treatment, conventional root canal treatment in true cyst. As I told you, the same pro-inflammatory cytokines and inflammatory mediators responsible for bone loss is responsible for proliferation of epithelial rest of melanocytes. So what happens? After you do the proper root canal treatment, you remove the irritant, the immune system starts to withdraw these pro-inflammatory cytokines and inflammatory mediators. Later, these inflammatory cells is going to withdraw from the area, and then they are going to make signals. These signals for death with the cells which you do not need anymore, which is the cell restoration. So you are going to start to have a series of programmed cell death through the process of apoptosis. Directed cell death to these cells, and then during the process of healing and healing go on. This is a proposed idea in the literature that we can have, because the healing we have is much more than the percentage of cysts. So definitely there's some kind of true cyst heals during the, but you don't know, because you are not going to do surgery to know the nature of the lesion. So the key is disinfection. And actually, we have seen disinfection, this case report, they are talking about disinfection in mature necrotic tooth, and they use the regenerative approach. They didn't fill the canal even. They just used the regeneration, bleeding inside the canal. And they had success. This lesion, large lesion, disappeared. If you can see, disappeared over time just by doing the regenerative process. In mature, retreatment in mature tooth. This is this case I like very much. It's one of my cases, and this patient was very interesting case. It was a young patient, and she came to me with this lower premolar, and I make a decision at the time to do regenerative endodontic. So I do the regenerative endodontic, and 7 months later, she came with an abscess. I was very upset, and before I see her, I thought what I'm going to do. And I said that I might go for epixification now. But when she came, I found that she lost her coronal restoration, or there was a leakage, I think, from the coronal restoration. So I started to think, this might be because she lost the restoration. She had infection again. And I made another CBCT. And this is what I found. Lesion decreased, or radiolucency decreased in size, meaning that healing process started and stopped. So I decided to go again for regenerative endodontic in this tooth. And I have done that, and she disappeared for about 4 years, and then she came completely no radiolucency, but the tooth is broken. The tooth was broken, but as you see, there is no apical radiolucency anymore. And you can see some radiographic changes in the root. You see this root there. This root here. There's some kind of calcification inside. So we decided that we go for some kind of root submersion. I don't know if you are familiar with root submersion or not. We wanted to keep the space until the time of implant placement. So we kept the tooth with root submersion, so we keep the bone level as it is. Okay. Again, I emphasize that cleaning and shaping is a very important step in our procedure. This study was very interesting that they found that when they do a cleaning and shaping in dog teeth, and they did not fill the canals, and they do a cleaning and shaping and fill the canals, success was not different. There was no significant difference in success. So before you start, the conclusion from here that before you start to think about more aggressive line of treatment, you have to convey, or you have to look for the possibilities in your hand for the conventional methods, because usually we don't like to go for more aggressive means in our work or our clinics. Okay, before I finish my lecture, I invite you all to join us for the Ban-Endo from Africa to the World, which is going to be held in Cairo here, December 10 to 13 in Cairo, Hilton Heliopolis, which we can confirm قبل كده اهوت. We have a very strong list of speakers. this only a small part of the speakers we have. We have 5 halls will be running at the same time, all endo. So welcome you all in December, and thank you very much for being here today, and I hope it was not very boring lecture.
Dr. Ahmed, on behalf of the organizing committee, I would like to present this certificate. Thank you so much.